Okay, everybody, welcome to this week's Infection Control Matters. My special guest today is Mark Wilcox, who is Professor of Medical Microbiology at Leeds University. He also leads the R&D department at Leeds University Hospitals NHS Trust. He's the Infection Prevention Lead for NHS England and advisor to the Department of Health and Social Care. Recently awarded an OBE. Welcome, Mark. Thank you very much for agreeing to chat to me.
Pleasure. Nice to see you, Martin.
Now, Mark is a world expert on the topic we're going to be talking about today, and it's something that increased steadily throughout the 90s, peaked in the early 2000s, then a decline, and possibly is on the way up again. So, Mark, what's your impression of what's going on at Manchester United?
Yeah, okay. And what about, you don't want me to talk about that? Let's talk about C. diff.
No, let's talk about C. diff. I was just joking.
Yeah, sure.
C. diff. Yeah, I mean, you've been involved with it a long time. Can I just firstly take you back to what first got you interested in it? Because you were into C. diff long before the numbers started to really rise, weren't you?
Yeah, that's a good question. So way back in my training days when I was in Sheffield, I wrote my first review article my first article at all about C. diff. And that was in the 90s. And basically, I started looking at the data about and the evidence for relapses versus reinfections. I thought the terminology C. diff associated diarrhea. Do you remember that? C. diff?
I do.
Just didn't quite do it for me. And so I started looking at the evidence, and lo and behold, that there was a lot of just misuse of terms, and out of that article, which was published in the Journal of Hospital Infection, that was where my interest was born, and subsequently, I think I was probably responsible for coining the term C. diff infection. It hadn't been used previously. I got into diagnostics because, lots of different ways looking for C. diff, some of them very non-specific, albeit sensitive, and vice versa. Infection prevention became my main interest, professional interest within the infection arena. And because C. diff was exploding, unfortunately, in the early noughties now, I got heavily involved in what I think it's fair to say was a public health campaign in the UK to try and control it. And we threw the kitchen sink at it, and it worked. Of course, when you throw the kitchen sink at something, you then start to ask the questions, well, which elements of the kitchen sink were the crucial ones? But that's the potted history of how I got involved in C. diff.
As you say, that's the problem, isn't it? When you've got a problem, you throw everything at it. So therefore, working out which is the biggest bang for buck has been a bit of a problem. But the bottom line is, as you say, it did work. I know at the time we were challenged by a particular strain, the 027 strain, which exposed, if you like, cracks in our system, I think. But we got a lot better, didn't we, about antibiotic control. We started to employ antibiotic pharmacists. Now, we do good root cause analysis, and the numbers came down. But we're starting to see a small increase now. Firstly, that's in England only, because we have very good data here. Is that mirrored in any other country, do you know, in the world? And did their numbers mirroring coming down like they did in the UK?
Yeah, so we have by far the best data in England and indeed in the UK. Compared with any other country, we've got a true national surveillance system or systems, so we can accurately count cases. I don't think we accurately count every single case, but the great majority, I think we do. And I think when we see increases and we see decreases, I think they are genuine increases and decreases. Then the magnitudes might not be exactly correct. But if you contrast that situation with any European country, and indeed with the US of A, they have very poor data to get a handle on what the true incidence of C. diff is and whether it truly is increasing or decreasing. I think what all countries are plagued by is the ascertainment bias issue, which sort of touched on earlier. If you're using either poor methods or a whole variety of methods to detect C. diff, then the data will be manipulated, sometimes willfully. And actually, when we introduced various targets, despite having to try and control ascertainment bias by having some very strict criteria on how to diagnose C. diff, there was evidence that some organisations tried to, let's say, steer how detection should occur. And I feel to this day very strongly that is doing great disservice to patients. Because if we don't accurately detect the cases that are there, how can we accurately control transmission from those cases? The US has seen exactly the same thing, but probably to a greater degree, actually, because they caught a long time ago something called PCR-itis. It's the term I've used, where they just threw PCR as a really sensitive method at C. diff diagnosis, and as a result, overdiagnosed C. diff. Then their targets came in. They're still there to this day. And you now have these bizarre situations where they've cooked up various control mechanisms for how test requests are agreed or not agreed to try and prevent the overdiagnosis. Anyway, so your base question was, have other countries seen what we've seen recently, starting in the pandemic, this uplift in cases? And the reports that have been published from other countries do not mirror what's happening in England. And that's disturbing. Now, that's either because ascertainment bias is masking the effect that we're seeing in the UK, or that something is different about us compared with other countries. Now, it's no secret that the NHS is stressed. Some might say historically stressed levels of stress. And no doubt, and you used the term earlier, I think it's about C. diff finding the cracks in the system, which I think is a really apt term. And that there are more cracks in the system at the moment. Plus, for 3 years, the best part of 3 years, we implored healthcare workers to concentrate on the transmission of an airborne virus. And the control mechanisms for an airborne virus are clearly different than the control mechanisms for a bacterium spread by fecal oral spread. And so I'm not convinced at all that we've got the level of optimization of infection prevention and control of C. diff back to where it was pre-pandemic.
I mean, we can rule out a new strain coming along to challenge us, can we? And we can rule out change in antibiotic use back maybe towards quinolones, which I know gave us problems before.
So indeed, we've looked hard for those would be the first things you'd look at, so because antibiotics cause C. diff. So that was the first thing we looked for. And quantitatively, we can't see evidence for shifts in prescribing. So if anything, the overall amount of antibiotics being prescribed is moving downwards slowly, or plateaued. But it's not going up qualitatively, so are we using more C. diffogenic antibiotics? Well, there's no evidence for that. I'm not saying in some places that might be happening, but overall, the 3 Cs, that we tried to control are being controlled. So the antibiotic use, put simply, does not appear to explain this uplift that we've seen, which is primarily in hospital-onset cases, but not exclusively.
Okay.
The other point you mentioned quite rightly was, have we seen a shift in the C. diff types that are causing infection? And no, we haven't. Actually, when you look at the relative proportions of cases caused by ribotypes X, Y, Z, they're virtually unchanged. And just to be clear, yes, there has been a recent national incident raised around an emergent ribotype called ribotype 955. That's, as far as we know, there have been 50-something cases of 955, which is far, far less than 1% of all the cases that we see. So that's a sideshow, and hopefully it will remain a sideshow.
I was going to ask you. I was going to ask you about that, because people were drawing an analogy at a meeting we were both at a couple of weeks ago, saying it's similar to 027, and we know what 027 did to a creaking NHS. Are you concerned that 955, if it got a foothold, could do the same sort of thing?
Yes. I don't want to overplay 955, but absolutely we didn't want to underplay it.
Yeah,
and that's actually why we decided with UXA colleagues that it was appropriate to raise this as an incident. I remember that very clearly in the early days of 027, because in Leeds, we were ribotyping all our cases real time. And so we saw what we thought was the first, second, third, and so on, 027 in Leeds. And they were largely indistinguishable, those cases, from the normal CDI cases. So not each and every 027 case is not a typical hypervirulent case of pseudomembranous colitis and toxic megacolon. They remain the exception, although they're more likely to occur. And it wasn't until 027 got into our particularly vulnerable patient populations in numbers. I mean elderly medicine, and I mean renal medicine. That's when the proverbial hit the fan, and things changed. Now, if 955 were to do the same thing and get a foothold in the most vulnerable patient groups, it has the credentials, the 027 credentials, genetically, potentially to do the same thing. So, yes, that does remain a point of concern. I mean, actually, the last case we detected was weeks ago. So, fingers crossed.
Fingers crossed, yeah.
And that it's not going to be 027B.
Okay. I was just wondering if those, for example, those strains, those variants are A, more transmissible, or B, smaller infecting dose if they're not more virulent. Do we have any idea about that?
Yeah, so, to this day, we don't know what the infectious dose of C. diff is in terms of how many spores you need to swallow. It doesn't sound very nice, does it? But
it's true, though, isn't it? Infection prevention is about stopping something going from one orifice to another. That's what we're trying to do here.
It is. Yeah. We know that there are data on the infectious dose in mice. It's obviously easier to do those experiments. And actually, if you stop to think about it, the infectious dose for you and I would probably be rather large, assuming that neither of us have had antibiotics recently. If give us antibiotics, and almost certainly that infectious dose reduces. And if you give us, the wrong sort of antibiotic to which C. diff strain I'm about to swallow is relatively resistant, then again the infectious dose will drop further. So is 027 and its cousins, including 955, is the infectious dose lower? Well, we don't know. I suspect what we do know is that patients tend to have more pronounced symptoms, not everyone, but more pronounced, tend to be longer, tend to respond less well to antibiotics, particularly metronidazole, which we need to leave as a historical interest, preferably. And so the potential for transmission, if symptoms are prolonged and or more severe, is greater. So I think that's the simple reason. If you look at there was always this argument that hypervirulent strains produced more toxin. We think from model data, what it is that the area under the curve, the toxin curve, is greater because it just carries on. And we know that the regulator in the gene, the toxin gene regulator that says stop producing toxin, so it's a negative regulator, that's defunct in 027 and related strains. So if it doesn't switch off, it just carries on going, more symptoms, more potential for transmission.
Yeah, I mean, you mentioned metronidazole should be consigned to history. I mean, it was cheap, which I suspect is why people hung on to it. But the more modern antibiotics like fidaxomicin actually reduce shedding more quickly, and I think I've seen papers from David Webber in the States showing that they actually reduce the level of environmental contamination. So that's got to help. Apart from helping the patient, it's also potentially going to help reduce transmission, because metronidazole didn't really seem to affect that quite as much.
There's a study that was done in Guy's hospital and one that we did in Leeds. I don't know about David Webber's, but those two studies, the UK ones, both showed, as you just said, less environmental seeding in and around individuals who'd received fidaxomicin versus vancomycin. I have no doubt the same would be true for metronidazole. Actually, for these recent 955s we've done the antibiotic susceptibility testing, because we don't do that on each and every strain. Obviously, we don't culture them routinely, and unfortunately, virtually all of them had 955s had quite markedly reduced susceptibility to metronidazole. There's always this grey area about what's resistant and what's not, because the breakpoints aren't necessarily set. But if your maximum level of metronidazole you can achieve, the absolute maximum is 9 or 10 milligrams per litre, or should it be per kilogram of feces, and the MIC is 2, 4 or 8, it's far too close. And so there's good evidence that effectively these strains are on the way to being resistant to metronidazole. We know metronidazole produces less good clinical cure rates, more recurrence. We shouldn't be using it. They always say the most expensive antibiotic is the one that leads to the need for retreatment.
That's true.
That's a good way of looking at it.
Okay. Do we have any data at all on what the cause infection that leads to the antibiotic that leads to the C. diff is nationally? So, are people doing robust root cause analysis and saying, okay, we've seen an increase in maybe non-ventilator associated hospital-acquired pneumonia because possibly nurses have been not quite as keen to go near patients' mouths during a time of COVID? I mean, is there any underlying infection that's driving the treatment, which is driving the increase in CDI?
Yeah, that's a good question. What we are trying to do is to look across specialties and say, is this increase that we've seen recently, starting in the pandemic, is that localized in certain specialties? And anecdotally, for example, we were hearing more cases being associated with hem-onc patients. When we look at the data, we can't see any hard evidence of that. And if you think about it from a numbers point of view, the great majority of C. diff cases occur in general medicine, particularly in elderly medical patients, be it in general medicine or in elderly medical beds. And if there is a national increase in C. diff, as there is, it's very unlikely that an increase in hem-onc patients could drive the overall national data. And it doesn't appear to be the case. That's not quite answering your question about, is this, down to hospital-associated pneumonia cases or whatever. We don't have the data for that because we haven't got the linkage data. But, I think, to go back to our earlier points, that the most likely, but unfortunately by far the most likely explanation is a series of, for the increase, is a series of cracks that C. diff is exploiting. And until I think we can get the system, the cracks filled with polyfiller or whatever, and more to the point, get teams, and this isn't just infection prevention and control teams, obviously. They know what needs to be done, but get teams in general concentrating on what we know was effective before, then we're not going to get back that level of control. It is attainable, and we're still 75% down.
Yes,
numbers on where we were, and we shouldn't lose that point. It's still
absolutely. Yeah, I completely agree. Now, you sort of mentioned it earlier on. One of the things when we were throwing the kitchen sink that came in, apart from people got better at environmental decontamination, et cetera, was targets. And as far as I'm aware, they're just an ambition now. And I know from talking to colleagues, they can't remember the last time anybody in senior management in the organisation asked them remotely about how they were getting on with regard to their ambition. And I don't think there are any penalties anymore, if I'm correct. I mean, I know there used to be financial penalties, or people would at least come and look and say what's going on. Would you welcome that sort of approach coming back in? Because I have to say, I've come from an era of targets, and I think it was the only thing that turned me from being the person in the hospital nobody wanted to talk to being the person that nobody wanted to talk to, but they had to, which is a different thing.
Well, the short answer is absolutely yes. I'm a fan of targets. They were painful for you and I when we were being held accountable for the delivery of those, but it gave us teeth, it gave us a voice, and it gave a focus that I don't feel is there now. And, is it any surprise? Just, this is not a political comment, it's an observation. Is it any surprise of the weights that are seen in A&E now? The magnitude of those weights have gone in this direction since the 4-hour targets were removed per se. So okay, no one wants to set a series of targets that are unachievable, but having I think it helps everybody. I think it gives clarity, gives people something to focus on, be it a ward sister, a nursing assistant, a junior doc, or whatever. At the moment, when the infection prevention control team go around and say, that C. diff control's not optimal here, that might look at them and think, well, tell me what is optimal, but they haven't got a target to point to say, but this matters and this isn't going away, and this is mandatory, this target. So absolutely, I think it was a welcome revolution that the target culture that was brought into the NHS, and thankfully the infection targets were a large part of that revolution, and I look forward to the day when they return.
Yeah, I mean, for me, they always made people think why and ask questions, whereas at the moment there's not enough questioning going on at senior management. So.
Absolutely.
Okay, well, come the revolution then. Well, thanks very much, Mark. I really appreciate you chatting to me. As it's nice to highlight the fact there's no big problem that it's multiple small problems that people are going to have to try and work out locally. And And I'd love to get people going back to proper root cause analysis with people sitting around the table and working out what's going on in my organisation, and then throwing that up the chain so that people further up the chain ask a few questions.
Just on that, just very last one, I've got some anecdotal evidence from colleagues actually in the east of England where they've started to try and do essentially root cause analyses at the bedside, almost like as part of the ward round, because remember the problem, of course, with a traditional RCA meeting is it
getting
happens
people,
down the line. Can you get the right people there? Do they all remember, and so on? And they're seeing anecdotally some improvement in reduction of cases because it's more instantaneous. So some hope there, and I hope to see some hard data soon.
Oh yeah, it'd be nice if they would be prepared to speak about that at some meetings. So that'd be good. Okay, Mark, thank you very much. Really appreciate your time. Let's hope C. diff carries on going down again, but Manchester United go up.
Indeed, Martin. Good to see you. Thank you.
And it's goodbye to everybody, and we'll catch you on the next episode of Infection Control Matters.